Okay, so I'm a sociologist, which is already specific in palliative care. I have 30 years of research experiences, but my presentation is, of course, also influenced by the type of research that I have been doing. So I think that's important to state that. I'm also a former co-chair of the European Association of Palliative Care reference group on public health palliative care, which will obviously be influencing my presentation. And I'm actually the president of Public Health Palliative Care International. So that's my statement. I think my first message actually is collaboration, which we have discussed over the last few days already. So my research team is based in two universities, University of Ghent and University of Brussels, also on two medical campuses with two university hospitals. So it's called an alliance research team, and that's an established department in the Belgian universities. So you can have a department across different universities in Belgium, which was an advantage for us because we were collaborating already very intensively with Ghent University ages ago. Ever since I started my research, I was collaborating with Ghent University. And so we established an alliance as soon as it was published and agreed in the parliament. We were, I think, actually the first who went for an alliance research team. But it's also interdisciplinary. And from the beginning, I was one of the white birds in palliative care as a sociologist, because most of my colleagues were either physicians or clinicians, psychologists, or whatsoever. And so from the beginning, I found it a bit weird to be as a sociologist in the field of end-of-life care and palliative care. But actually, along the pathway of my career, I found it more and more interesting to be a sociologist. And at the end of my career, which is, well, when I retired last year, or at least when I started doing research again on compassionate communities, I understood fully the added value of being a sociologist. And I come back to that later in my presentation. So collaboration, I think, is the key to success. Ever from the beginning of my career in research, collaboration with the clinicians, with other disciplines, is the key of success. And I think we should realize that palliative care is a multidisciplinary, multi-professional area of research, very complex. You can't do it with one discipline. It's impossible. It's just impossible. It does not make any sense. So what I'm going to do firstly is going quickly over the history of palliative care. So what were the palliative care responses? Because the challenges of death and dying are exactly the same 30 years ago than it is now. So there's nothing there from the point of view of the suffering of the patients that didn't exist at the beginning. So what were the palliative care responses to the challenges surrounding death, dying ever since the 1970s? So the first period, well, you all know the history of Cicely Saunders and other founding mothers and founding fathers of palliative care. They were actually doing political activities. They were lobbying for money, for establishing something which could support mainly at the beginning cancer patients who were suffering terribly. So that was, and a very good book which really describes it very well is the biography of Cicely Saunders, which was written a couple of years ago by David Clark. You probably all know David Clark. That's a really, really beautiful book. It explains very, very, very interesting stuff, even about euthanasia. Assistance in dying, there is issues. One of our best friends was one of the advocacy for legalizing of euthanasia, although she always was against legalizing of euthanasia. But that's very interesting biography if you want to read about the first stage, which I call the first stage in the development of palliative care. So the second stage, and we're still in that stage, in many countries we are in that stage, started more or less between 75 and 80, when we started to develop, actually we started to professionalize palliative care. That's what we did. We professionalized palliative care, professionalization by training of clinicians, training of doctors, training of nurses, but also by creating models of care, multidisciplinary, multidisciplinary and interdisciplinary, there's a big debate about the difference between these two. I can have a lecture on that. In palliative care, very often interdisciplinary care is not reached in palliative care, in my view, but it's multidisciplinary care for sure. So we're shaping the field of a new kind of medicine, new kind of care domain, and integrating also the care models into existing care institutes. That was the so that's the second phase. So what we did is actually policy-wise, and this is the policy pyramid which I use often in my lectures. So palliative care development with a main focus on specialized palliative care. And if you ask people in the street what palliative care is, very often they will only refer to specialized palliative care. That's what even doctors will only refer to palliative care as specialized palliative care services. So it's professionalization, it's medicalization. I think one of the issues what happened is a very, very rapidly medicalization of the service of palliative care, although Sister Sanders didn't mean that at all, without noticing the wider picture. And that's, I think, important to realize that the wider picture will give you some other perceptions on what palliative care is. So the third stage can more or less be defined in the year around year 2000. And from that moment on, we were trying to mainstreaming palliative care. What does that mean? It's trying to integrate palliative care into regular caregiving. The Dutch were the ones who did it brilliantly, because the Dutch for a very long time didn't have any specialized services, but ever since the year 2000, they were training their primary care physicians in palliative care. So that is what we call generalist palliative care. And so many of the problems in palliative care can be solved by this generalist palliative care. So the integration into the health services started that. And then ever since the Tamil study, which you all know, the Tamil study showing the efficacy about early palliative care, we started also to try to develop models of early integration. And that's a little bit later, of course, after the study was published in 2010. So that is the second layer of the policy pyramid of palliative care. So under the specialist services, we have the generalist palliative care skills. And that is also still ongoing. And in many countries, that is not well developed. And there's a huge benefit from developing by training, by making it obligatory at schools, nursing schools, medical schools, physiotherapist schools, any kind of clinical discipline who is working in primary care should really have a basic training in palliative care. Today, for example, in Belgium, oncologists are not trained in palliative care. Per definition, they do it on a voluntary basis. But in a country like, well, it's not a country, but Catalonia, a region within Spain, every oncologist has the duty for a 3 months training, internship training at the palliative care ward. So that should be the training model for every oncologist in the world, in my view. They should have basic skills in palliative care. And the same for, luckily we know if in Belgium, for all the general practitioners, they have basic generalist palliative care skills when they are trained at universities right now. But what only begin to start developing is the stage number 4. And that's the civic responses to the challenges of death, dying, loss, and bereavement. And that only started more or less by 2010. It's the public health approaches. It's called public health approach. Sometimes it's called new public health approaches as contrast to the traditional public health approaches. And it's the development and implementation of community interventions, like compassionate communities. And that was rather new. So this is actually the basic of for me, the basic of the policy pyramid of palliative care. Because what we haven't done is looking into the society, which existed already. It has been mentioned in the conference yesterday and today also. I mean, 50 years ago, we had a normalization of death, dying, and caregiving in the community. People were living in big farmhouses with multiple generations. Everyone is taking care of everyone. And still in Africa, they say, you know, it needs a village to raise a child. It also needs a village to take care for the dying in your community. And that's why you need community approaches and not isolated into specialized services. And that's the biggest mistake we've ever done in palliative care, thinking that we could solve the problems with our specialized services. And right now, everyone knows who is in policy, who is in palliative care. It's the model that we have on palliative is not sustainable. You will not reach 100% coverage of palliative care with the models that we have. We, in most of the countries, reach out less than 20% of patients that have access. If you look at it on a population level, less than 20% have access to palliative care specialized. So the largest potential to create, and we are discussing that for years and years and years, the largest potential for palliative care increase in the capacity is within the society. It's not within our services. It's in the society. So that is a lot. And of course, these levels are interrelated to each other. I don't have to go into details for that. But if you have a very good established generalist palliative care, there's less patients who need really the specialized palliative care services. And if you have a very well-established environment, social environment, many of the problems are already solved on a societal way before they need to be medicalized into the healthcare system. So how much evidence do we have on palliative care? There's a massive evidence, so I don't think we need a lot of more evidence. There's an exponential growth of an evidence-based practice in palliative care. There's a substantial evidence has been published in scientific journals. There's also substantial growth of the number of palliative care journals. It's amazing just how many palliative care journals there is these days. And synthesis of the evidence-based palliative care have been published in a large amount of textbooks, from the Oxford textbook to the Springer textbook to many other textbooks. In conferences, there's an explosion of the number of conferences in palliative care. I keep seeing people like here in the audience in different conferences, on different continents, education, training, and palliative care is fully recognized as a separate field in medicine. So these are only few of the studies, but there's over 30 RCT studies showing the benefit of early palliative care integration. So we do not, and all these studies have a range, has been conducted in a range of countries with a range of diagnoses, with a range of settings in oncology, in home specialist palliative care, ICU, but also with a range of early at diagnosis or early at incurable cancer, with a range of models that is being used, nurse-led models, doctors-led models, but also multidisciplinary-led models, also a range of primary outcomes that we use on patients' level outcome, caregivers, but also showing benefits not only for patients, but also for families and for the health service benefits. So the big question is now, is there a discrepancy between the evidence and the practice? That's the big question. And for me, this is the big challenge for palliative care for the coming 20 to 50 years. That's bridging from the evidence to the practice. So if we just look at when do people get access to palliative care, a very simple question. This is a systematic review that I jointly did with the group of Mike Bennett. I don't see it. You have also this bar at the bottom. No, that's okay. That's okay. But anyway, you cannot read, but I will tell you it's a publication with the group of Mike Bennett, a systematic review where we reviewed 169 studies from 23 countries. With an inclusion of more than 11 million patients. And prior to that, the median durations from initiation of palliative care to death is 18.9 days. So less than 19 days in all of these studies. So who is speaking about palliative care, and why don't we still speak about terminal care? Because that is the message we give to our patients, that is the message we give to the society. And that's why there is still a big taboo about the concept of palliative care. Because in reality, people are not stupid. They see that it's terminal care. That is the reality. So that is around the corner. And that's why people don't like palliative care. So we should haven't called it palliative care. We should have stayed until it was changed into early palliative care. And then we could call it palliative care. Anyway, so there's significant difference between the durations were found dependent, of course, of the type of disease. And of course, you can imagine that cancer patients get earlier access to palliative care than non-cancer patients, which came out of this review also. But also the service type made a difference. 19 days for specialist palliative care units, 20 days for community home care, palliative care, and 6 days only for general hospital wards. So you're not best off in hospitals, huh? If you want to have palliative care. So this is the discrepancy between we are discussing for now ever since the Tamil study in 2010. We are discussing at each conference that I attend about palliative care and early palliative care. The reality of the practice is that we are delivering terminal care. That is the drama, I think, and also it has a huge impact on our communication systems. There is some improvement. This is a study from Australia, from the group of Jenny Phillips and Anna Collins, showing for lung cancer, prostate, and breast cancer, there is indeed an improvement from 2005 to 2018, that the overall access for these patients increased. And this is a university hospital there, from 54% to 60%. However, if you look at the duration, that decreased over the time, over a period of more than 10 years, from 25 days to 22 days. And however, the receipt of early palliative care increased significantly from 10% to 18%. So there is improvement, but also not really, really big improvement. So how well do we perform in palliative care? I would say too little, too late. That is, I think, in a nutshell, the conclusions of 20 years of research. So it's still dominated by terminal care. It's prognosis-driven rather than needs-driven. It's early integration that failed completely in most of our industrialized countries. And we are talking about early palliative care. And after 15 years, it takes a little bit of time to implement something, but 15 years is enough to have a little bit more of a practice developing than just a rhetoric support for early palliative care, as we all know. So now the big question is then, how come that palliative care, only 10 minutes? Yeah. Oh dear. How come that palliative care and palliative patient-centered care is poorly integrated into our healthcare systems? So I think I'm going to go quickly over these. I mean, there's enough historical reasons for that. I mean, the whole healthcare system is very much focused on disease. It's disease-oriented. I always say, kiddingly to my colleagues and to my family, a hospital is not a care institute. A hospital is a highly sophisticated institute for diagnostics and for treatment of diseases, not for caring for people. And we don't realize that enough in our communication to patients, to communities. And anybody in the community will say, you know, if there's a problem, I go to the hospital. If it's a problem on the level of care, you shouldn't go to the hospital. Because, I mean, in Belgium, on average, for connected to oncology wards, at night, there's 2 nurses in the night. So how can you do good end-of-life care? Because on both of these oncology wards, there will be dying patients. How can you do? So it's impossible. So there are cultural reasons. You know, I have spoken already about the taboo issues, and families and professionals are often view palliative care as giving up, because that is around the corner, and it shouldn't be about giving up. There's fragmentation in the healthcare system. There's so many silos wherever I come in hospitals. There's so many silos, a lack of collaboration, a lack of coordination between these silos. There's a lack of training still, a lack of an awareness. Of course, we are not supported by the reimbursement models that we apply for palliative care in most of our countries. And I still think also there's a lack of leadership in a hospital. I mean, the CEO of the hospital should be completely convinced about the added value of palliative care. If that CEO is not convinced about the added value, you will not change in a systematic, so there need to be systemic culture change in a hospital in order to integrate palliative care into a hospital. But I think also we are the ones who are failing also in research. So as researchers, I think we have to look into the mirror also, and this is from a review also looking at palliative care research priorities. And the conclusion of that review was that the voices of professionals or professional care providers are dominating in this research. Too few research is capturing patients and families' perspective, and more research is needed to understand the working of the healthcare systems, both from a structural way and from a cultural way. As a sociologist, that's the first thing you learn. It's not only about the structure of your country, it's also about the culture of your country. And so if both are not into place, you can never implement advanced care planning in a hospital, because you need to change the structure, but most importantly, you need to change the culture of how doctors and nurses communicate with each other, how doctors refer patients to other wards, etc. So that is very important. So the burning challenges for palliative care services, the present models of specialized palliative care in many countries is no longer sustainable. I think many of the models of palliative care have been based on clinical and health services model, not on public health models. So I probably won't get through my presentation, but what are the possible pathways? And I have developed two pathways for you to improve implementation of palliative care. And you have to tell me, François or Olivier, how long I can still go on. So there's two pathways that I can still develop, but can I also stop here if you want me to stop? Okay. So the first pathway is implementation research. I mean, there's very little implementation research in palliative care being done. Meaning implementing of an evidence-based practice in palliative care into real-life medicine, into real-life healthcare systems. And secondly, my second pathway is the promotion of public health approaches in palliative care. But quickly about the implementation side. So what is implementation sciences? That's a definition. It's a scientific study of methods and strategies to promote systematic uptake of research findings and other evidence-based practices, include routine practice in your healthcare system. So what it's actually doing, implementation research, is looking at the transfer from a protected environment of your study into the messy, uncontrolled conditions of reality of our society and of our healthcare systems. That is actually what, so you look at the conditions in which possibly actually your evidence-based model intervention will work in practice. And you will look at the barriers and the facilitators to make it happen. So while you're doing the research, that is actually what, and there's very little, if you look at journals like Palliative Medicine, there's very little papers on implementation sciences in palliative care. So why do we need it? Clinical as well as health services research have little guarantee of a public health impact. Effectiveness trials typically depend on research resources which are separated from the regular clinical infrastructure. And the consequences for regular care is that it's short institutional memory. It has a short institutional memory, meaning that as soon as the study finished, it may continue a little bit after a few months, but after a few months, it will disappear into the system. So there's no further sustainability of your evidence-based practice into that. So they all fall back into the old routine. And often there's also no technology transfer. And the problem is that if the translation of the evidence practice is not assisted, it's unlikely that it's going to be sustainable in your healthcare institute. So I'm not going to go over all this, why we need more implementation research. I think we have to realize that more than 85% of all healthcare research is being avoidable waste. It's what we all have experienced as researchers. We publish our paper. If you're lucky, maybe 10 people would read the paper. If you're very lucky, 100 people will read the paper. If you're very, very lucky, they may congratulate you with the paper. And for the rest, it disappears in your office. And it's not being used in practice. So there's a lot to say about how poorly we disseminate our results also. That was my fourth pathway, but I couldn't fill in the fourth pathway. So I think also we have a small amount of the budget of research. So we should be very careful how we manage the budget of research in palliative, much more than in normal circumstances. So there are several barriers and that can impede the uptake of evidence-based practice, competing demands, lack of knowledge and skills, lack of resources. So there is a clear need to develop specific strategies to promote the uptake of evidence-based practice into routine palliative care. And that's a formula which is often being used in implementation sciences. So the implementation success is dependent on the strength of your evidence, how ready the local context is for the implementation, and what's the availability and the quality of the facilitators present in your. So I'm going to go over to my second pathway, which is potential of public health, palliative care intervention and research. So a public health approach covering death, dying and loss is lacking in palliative care in most of the countries. Public health intervention approaches like health promotion, death literacy, compassionate communities have only very recently been developed. And I think the key message which I want to give today here in Quebec is if we really want more policymakers, practitioners and communities to embrace the aims and ideals of palliative care, a public health approach is an essential condition to do that, complementary to the clinical and health services approaches that we all know. And we don't realize in palliative care that public health and health promotion have enjoyed a strong support from governments since the 70s. I mean, the WHO has developed a huge amount of policy programs to promote health in societies. We had, by the 80s, we had health for all by the year 2000. But the results of that is that actually we transferred the responsibility for the health from the doctors, literally in my parents' generations. The only one who was responsible for that's the the war generations. They were living unhealthy. They were eating a lot of fat. They were smoking like hell. They were drinking like hell. And they didn't feel responsible for their health. It was if they were sick, they went to the doctor. And the doctor is responsible. So in a few generations, if I compare myself to my parents and to my kids, I mean, there's a huge cultural revolution happening in moving up that responsibility from the doctor to the society and to the individual people in society, but also into the collective of the society, not only individuals. If we drive a car in the morning to our offices, I mean, there's hundreds of public health measures that makes you safe driving from your home to your office. We don't imagine that a car is a safety protection feature. but there's so many features in the car that makes us safe to drive with the car. Well, now I've known the time when there were no seatbelts in the car. Now there are beepers going off, getting you crazy if you don't put on your seatbelt, etc. But also the traffic lights, the conditions of the, etc. So many measures, and the Parliament has made hundreds of decisions about how to make driving on the public roads safe. So we should, so public health and health promotion is giving, okay, thank you, more attention to prevention and health promotion, etc. So it's the collective dependent of the individual patient care at end of life. It is broader than, and that's important, it's much broader than the health care in the strict sense, and includes, it's multi-sectorial actually. So last time when I went to the Minister of Public Health in Belgium, I said to her, and that was before we had general elections in Belgium, I said to her, I'm not going to beg for, again, for more money for palliative care, but please do me a favor, I said to her. And I knew that they were going to negotiate the next governmental agreement. I said, if you sit at the table for the negotiations, please put responsibility of public care, of palliative care into the baskets of all the ministers. The Minister of Education for promoting death literacy at school, for bereavement care at school, the Minister of Economy to create more compassionate workplaces, the Minister of Sport also to get engaged into community. In Bern, for example, that they use the big screens in the football stadium to make messages about compassionate community, because Bern is a compassionate city. So that's, every minister has a part of his responsibility. As long as the policymakers don't understand that palliative care is about different sectors in our society, we will not get where we should get at. So that is, so the capacity can substantially grow. Actually, what we have to realize in palliative care, and this is from the basic premises of the public health movement, is that that is still a social event. It's only a social event with a medical component, and it's not a medical event with a social component. And so if you have that in your mind, anytime when you speak to policymakers or politicians or whatsoever, and even for your own activities, if you think that through and use that statement for making your priorities in your research, in your clinic and so on, you always arrive at another outcome, always. And that's because we've forgotten that. We have been medicalized. What does that mean? As a sociologist, we learn that medicalization is also, it's a cultural issue. So medicalization means that I'm not responsible anymore. So the social aspect, which has a huge potential, is forgotten. It's really lost in that kind of medicalization. So what are the overlooked facts about palliative care? The longer part of dying occurs outside of the institutions, not in hospitals. Palliative care is not just about symptom control. It is also about grief, loss, and caregiving. It's also about family, not just the patient. And it's also about what matters most to you. These are a couple of issues which also are important, why we need more compassionate communities. I think we don't realize, but in palliative care, the needs in palliative care is for 80% and more social needs and mental needs. We know for social needs and mental needs that you do not have to medicalize them. We had a conference on grieving also. I'm grieving for the death of my sister, but I never had the need for a clinician to support me because I have social networks, enough social networks who have the same experiences, who share their experience with me. And you realize that it's normal that you grieve after the death of your sister. So you don't need to medicalize that. We have to give more attention for prevention. I'm really in favor of having laws for oncologists, for example, before they start having even to give experimental chemotherapy to their patients, that they need by law to consult a palliative care doctor before they can start up there. That's very simple. It's just Oncologists might not be happy, doctors might not be happy, but it's very simple by the parliament to vote on those kind of laws. So we need to see it in a structural, cultural way that we need to prevent suffering in our society. And there's lots of evidence of chemotherapy being given the last 3 days of life of cancer patients. I mean, we don't have to discuss about this evidence anymore. We have to make sure that we can prevent that. That is what we have to do in palliative care. So there's a whole field of research on public health palliative care over the years being developed. I'm not going over, we have conferences, we have textbooks, we have dedicated journals, we have compassionate communities endorsement programs by Public Health Palliative Care International. Big organizations like EAPC have a reference group on public health, etc. This is a little bit of publicity for myself. The next conference of public health, which is every 2 years, is taking place in Taipei in Taiwan in 2026. So the key challenges for policymakers is recognizing the limits to service provision and health services research, restoring end-of-life care to the wider public health sphere of policy, practice, and language, understanding and facilitating the principles that end-of-life care is everyone's responsibility. So we need civic approaches, and these are my last take-home messages. We should complement clinical research and health services research with implementation sciences research. We should complement clinical research and health services research with public health, palliative care research. We have to integrate more social sciences into palliative care activities and research. Compassionate communities like neighborhoods, workplaces, schools, universities. I will talk tomorrow about Compassionate University at Laval University here, is one of the promising models, and public health palliative care initiatives should be integrated into a global level. Thank you very much for your attention.